Good afternoon, and thank you for spending part of your day with us. We have a very exciting agenda packed with product experts and subject matter experts. You're all in for a real treat today. Steve Meurer has a PhD in health services, holds multiple other degrees, and has extensive experience in helping our members initiate positive change in their organizations. Amanda Hooper oversees our clinical and clinical to supply solutions portfolio, which includes clinical database, service line analytics, and the all-new procedural analytics, which you'll hear about today. Jill Cotchen has 7 years of industry experience and is one of our lead solutions executives and subject matter experts when it comes to the technologies I just mentioned. And so we're really excited to have this panel with us today. This is today's agenda, and what we're going to ask Steve to do is to cover the first bullet that you see here related to what's required to build and sustain an effective clinical analytics program, and how to overcome some of the challenges you may be experiencing in your organization. Amanda will then talk about the total capabilities of our clinical analytics platform and how you can accelerate improvement across the entire patient encounter. And then finally, Jill will dive deeper into the procedural setting with our newest addition to the clinical analytics platform called Procedural Analytics. To help us understand where you're coming from, we've inserted 3 polling questions into today's presentation, 1 now and 2 towards the latter part of today's dialogue. So if you could take a moment to think through the following question and respond. On a scale of 1 to 5, how well does your healthcare organization currently identify and act on clinical standardization opportunities for the benefit of both cost and quality? 1, extremely well. 2, very well. 3, somewhat well. 4, not so well. Or 5, not well at all. On a scale of 1 to 5, how well does your healthcare organization currently identify and act on clinical standardization opportunities for the benefit of both cost and quality? We'll give you about 15 more seconds to respond to that, and then we'll move forward. Looks like a lot of answer C's. So somewhat well, it sounds like some of you are kind of figuring things out as we go. 15% very well, 57% somewhat well, and 21% not so well. So good. Hopefully we can help move you along the path. Let's go ahead and start with our first presenter and our first objective. Appreciate your responses there. I'll hand the mic over to Steve Meurer to explain some of the key characteristics required for an effective clinical analytics program. Steve?
Great. Thank you, Greg. And it's a pleasure to spend time with you this afternoon. As Greg mentioned, my role at Vizient is to work with the hospital, quality, and physician leaders to help them improve using Vizient data, and that's improve in all domains, operations, finance, quality, and safety. And as such, I've spent time with healthcare leaders from more than 100 hospitals just in the last year, and I always will go in and ask them about their analytics and their quality structure. And while this may seem a bit controversial, I'm not at all convinced that what I'm hearing and seeing will alleviate Don Berwick's concerns. Don Berwick is the leading healthcare quality guru in the world, and he tells us that the biggest issue that we're facing right now in the American healthcare system is our inability to improve. I sent out a survey a few months ago and received 35 responses on analytics structure. And one comment sticks in my mind more than anyone else. A respondent simply commented, chaos. And that's what I see in a lot of organizations. So in order to understand the characteristics that I believe might be effective for a good clinical analytics group, I want to understand why we don't do very well right now in the American healthcare system in improvement. So the next slide gets at that. And I turn to Avitas Donabedian, who is late of University of Michigan. And I love this definition of improvement because it's elegant, it's really complete. But in my mind, the best thing about it is when you boil it down, it suggests that we only need 2 things for an improvement to occur. And those 2 things are on the next slide. We need what I'm calling the right data, and then that data must motivate a change. Now, by the right data, what I really am suggesting is we need data that is transparent. We need data that you can drill down on, and we need data that organizations feel that their targets, they're comfortable with their targets, so they have appropriate comparison organizations. And by the way, for those of you at Vizient who use the clinical database, these are the key differentiators of Vizient's clinical database. These are the things that are actually going to help you get to the point where you can motivate a change. And so this starts to get to the point and starts to get to the understanding of why we don't do very well right now in improvement. We don't do very well in improvement because we rarely get beyond data. We're arguing about data all the time. We're trying to go get more data. We're showing data that shows different things. And so what we really need to be able to do is standardize with a set of data that's going to help us get to that point where we can change. And what I'm seeing and hearing in hospitals is a bit troubling. It's actually a movement towards separating data and change. Said another way, I'm seeing a lot of hospitals that are moving analytics programs out of quality and into IT, and quality programs are there for the change component of it. So they're lean specialists or Six Sigma specialists. I'm also seeing our healthcare leaders make decisions to change based on information and not insight. So what does this mean? The next slide will describe that in more detail. So I will tell you that data in and of itself is not going to motivate change, even if it's the right data. And for that, it has to go through this process to insights. Data goes through a technology device, an analytic device to become information. And I will tell you that information doesn't motivate change either. And without the ability to drill down into that information and truly understand why you might be different, organizations are going to be left, and organizational leaders are going to be left making assumptions. And when you make those assumptions, you're going to end up making wrong assumptions many times where you're doing type 1 and type 2 errors, where you're changing things that don't need to be changed, or you're not changing the things that you need to be changed. So a quick example. If I were to go into an organization and tell them that their risk-adjusted mortality for cardiology was a red dot when it was compared to a custom compare group that organization wanted to see, that's information. That tells you that they're different than that group. It doesn't tell you why or where they're different. And in order to understand that, you have to hand that information to a person who can add context and understanding to that data to transform it into insights, and then take those insights and present them to the right people at the right time to motivate change. Those people I'm calling data scientists, and what I'm suggesting is that we don't have as many data scientists as we need in the American healthcare system, and that is a huge gap not only in our analytic programs, but also in our ability to get improvement done. I call these people data scientists because the Harvard Business Review calls it the sexiest job of the 21st century. But when you read that article, you also realize that there are different, essentially, flavors of data science. So if you go to the next slide, you will see that what the article suggests and what others have suggested is that there's really three different varieties of data scientists out there right now. There is the IT data scientist who can develop and support those analytic programs that are needed to transform data to information. There's statisticians. These are the individuals that are doing studies and developing manuscripts and publishing papers. And then the last two are the ones that I think we really need to cultivate and focus on in the American healthcare system. The data analyst is someone who's going to be more retroactive, who's going to be waiting for someone to come to them and say, can you write this report? Can you give me this information? But they will eventually become, and I don't think what we've done in the American healthcare system very well is we haven't taken data analysts and moved them to data scientists. It takes some time. It takes a lot of interaction with data and with people to be able to get to that point. But I love these 5 characteristics of a data scientist. Now, the trouble with these characteristics, though, are they're general, and they're very difficult to differentiate one individual with another. So I'm certain many on the phone are saying, well, I fit in that role of the data scientist. And you may not be actually in the area or in leveraged as much as you need to in your organization. But I would suggest that what we need is individuals who can take data move it all the way to insight, and then present it to leaders, present it to clinicians in order to motivate change. Next slide. What we've done at Vizient over the last couple of years is we've developed what I'm calling the improvement community. And the improvement community really is an accelerator for organizations to help them get to the point where they are going to improve. We're going to give you data out of our many databases. You're going to hear about a lot of that from Amanda and from Jill. But it's not just about giving you the data and leaving you be. It's about also providing you with some data science, with some insights, some support, the training you need, the collaborative, the networking, everything that you need to get improvement done, because what we've found is that improvement is a team sport. And so you need to be able to have a partner like Vizient who can provide all of this information, and you need to be able to also have networking with other organizations like you to help you along that journey. Your role is going to be threefold in your healthcare organizations. There has to be some leadership focus at all times in order to be able to get the improvements you want. You have to be able to cultivate data science in your organization. And I think if you do leadership focus and cultivate data science like I've described before, you're going to get engaged clinicians, which has always been difficult for us. And the next slide highlights why that's been difficult. Because Shannon Sims, who works with us at Vizient right now, he has taken the Kubler-Ross stages of grief and transformed those as the stages of quality measurement. And any one of us on the phone right now have heard those first four things over and over and over again. The role of a data scientist, the role of Vizient is to work with you to get to acceptance, to get your clinicians to, okay, maybe we can do better. The next slide. So before I pass it on to my colleague, Amanda, I want to summarize and tell you that I think there are 3 C's involved in the characteristics of an effective analytics program. Centralization, which really means that I want to move away from the trend where we're decentralizing everything between analytics and change, between financial analytics and operational analytics, to a centralized analytics program that is developing dashboards, that is producing dashboards, that's presenting those, that's drilling down on any opportunities and presenting that information as insights. Cultivating, that's the second C, cultivating data scientists from the wonderful data analysts that we have and making sure we're leveraging them. And then change. Eventually realizing that data is not the end. Data is what gets us to the change, and that we've got to move beyond that. So centralization, cultivation, and change are the 3 characteristics I would give for an effective analytic program. And with that, it all starts with data, so I want to be able to hand it over to my colleagues, Amanda and Jill, who are going to help you understand some of the data that we have that can get you to that change.
Thanks, Steve, and hi, everyone. This is Amanda Hooper. As mentioned earlier, I oversee a lot of our clinical analytics offerings in terms of making enhancements to the products and looking at our overall roadmap. So it's great to be with you all this afternoon. You can go ahead and go to the next slide. So just as Steve mentioned, now I wanted to take some time and just kind of back up to that first step of the process that Steve already spoke to, and really focus on Vizient in particular and our clinical analytics platform. And so when we talk about our clinical analytics platform, especially today, what we're really going to be focusing in on is our clinical database, our service line analytics offering, and then our new offering, as Greg mentioned, called Procedural Analytics. And as we look across that entire portfolio, it's really looking at across that entire patient encounter, whether it's an inpatient encounter or outpatient encounter, looking at some of those key quality metrics, some of the outcomes metrics, and then, of course, looking at what's that overall cost of care. And so if you go ahead and advance. So one of the key characteristics, and Steve already alluded to this in one of his earlier slides, is transparency. So we are a firm believer that you need to have transparency, whether that's with the methodologies and how the methodologies are calculated. That's also going to be a huge factor in how successful you are in being able to draw insights out of the data, as Steve mentioned earlier. So it's being transparent in the methodologies, and it's also being transparent in the comparison groups. So allowing you to select who you want to be compared with, and not only that, but when we're able to show those comparison groups and those names of those hospitals by name in the data so that you can trust the data and really use it to make those insights and drive change at your organizations. Now, with that said, we're not always able to provide transparency with the benchmarking, especially if we're looking at some of our applications that take in internal cost accounting data or maybe a report on contribution margin. And so in that sense, we want to make sure that our benchmarks are available by patient acuity across different cohorts and really allow you to slice and dice that data in a lot of different ways and give you a whole wealth of cohorts to select from. And then, of course, we have a lot of various quality metrics in the tool. We'll talk about some of them in a few case studies, but we're more than happy to answer additional questions outside of this webinar as well. But looking at length of stay, readmissions, complications, pulling in core measures data, pulling in your Nissen information, and then also marrying that up with some of the costing methodologies. So sometimes, depending on your use case, it might make more sense to look at something as more of a ratio of cost to charge, which is really going to allow you to compare across one member to the next to see where it appears that you have opportunity to reduce costs, and then allowing you to drill into specific resources to see what might be driving that, or maybe it's length of stay that's driving it, or your complication rate, or so forth. But then we also have costing methodologies that's more so pulling your internal cost accounting data and then allowing you to take that information, look at corresponding revenue, and do some analyses on contribution margin. And what that will enable you to do is then as you make change, you can correlate that back to what you're used to seeing in your own systems for your internal cost. And then we, of course, recognize that many of our members want to have that capability to just go in, just give me the raw data, and I want to do whatever analysis that I want to. And so we allow a lot of that ad hoc reporting, whether it's via a data download type capability or something more like the report builder for those of you that are familiar with the CDB, as well as having more data visualizations and kind of a click and drill through capability, which we've seen, some of our members, they want that ease of drill down and they want that presented in a more visual way. And then if they need to, they want to get to that data download. So as we're looking at our various solutions and we are working on merging together and integrating these solutions together, that thing that we're really keeping at the top of mind is having both that ad hoc reporting and that visualization. And then lastly, of course, as we're pulling these different product offerings together, we want to make sure that they're in one integrated platform, so it's one place that you can go to access all of this information that we're going to be talking about today and not have to go into different solutions to pull this information together. So as you all, we're hearing from you that you're merging together your quality departments, your supply chain departments, and they're really starting to come together and talk to each other more often, and we're also doing the same thing with our analytics offerings. And you'll see some of that on the next slide, where we're talking about the different types of utilization analysis that we're able to do within our various analytical offerings. So as you're looking at variation in care and understanding unnecessary variation and also looking for ways to potentially reduce the cost of care delivery, you want to make sure, of course, that you're looking at utilization data, not just of supplies and pharmaceuticals, but also, in accommodation. So what's your length of stay look like? How often are you utilizing the ICU services? How long are your patients staying in the ICU? And then looking at interventional services, so having very detailed information on neuromuscular, blood utilization, cardiovascular, vascular, PT, OT, respiratory therapy, you name it. And then lastly, diagnostics. So there's a wealth of information available to you, lab tests and imaging services as well. And we'll have a couple examples of the various products here on the next slide. So again, this is really focusing on our core clinical analytics elements, knowing that, of course, we have, a wealth of services at Vizient, including our PSO, our core measures offering. We're not really going to focus on that today. Just wanted to give you a basic understanding of our clinical analytics for those of you that are not already familiar. So this is a very, very high level, but when I think about our clinical database, Steve referenced it a couple times throughout his portion of the presentation. I think about having that completely transparent clinical performance improvement and utilization management. So your clinical database is where you're going to go to do most of your quality analyses. It's where you're going to go to look at utilization, particularly around the non-supply items. And then service line analytics, it's another offering that we have. Actually came from our MedAssets portion of the company that we acquired. And that really looks at, again, like the clinical database, the entire patient encounter for inpatients from the time they're admitted to the time they're discharged, but has a different focus than the CDB. So CDB, again, is used more for that performance improvement. Service line analytics is going to look at how can you reduce the overall cost of your care. So everything in service line analytics ties back to what that potential opportunity is. So I always say it has a light lift of the CDB in terms of it does bring in some of those basic quality metrics so you can have that more holistic approach. But the real focus is on looking at your internal cost accounting data, taking those supplies, connecting it back to your purchase information, and then looking at the corresponding revenue of that case and contribution margin. Now, our latest part of this product family that Jill's going to spend some time talking about is procedural analytics. And so I always describe this as it's like taking a magnifying glass on that procedural setting within SLA or service line analytics. And so what that does is it looks at areas like your operating rooms and your cardiac cath labs and looks at all of the supplies that you're using in those areas and allows you to look at that so you can see what patients received what supplies, what physicians are using what supplies, what manufacturers are being utilized, and then connect that back to data that we have in various applications at Vizient, including our supply chain database and our clinical database and even service line analytics. So again, we're really focusing on integrating all of these products together. Now the next few slides will give a couple different examples, really focusing on the types of questions that each of these clinical analytics solutions will answer. So what you'll see in this slide is, this is just an example, our kind of fake patient here of Joe Smith. He's gone to the hospital after a bad fall. And you can see, you can follow this patient from admit to discharge. So he came in through the ED, was given imaging services, then had to have surgery, stayed overnight in the orthopedic unit, and then later was discharged home. So we'll kind of take this fake example here and walk through on the next slide what types of questions the clinical database in particular can help you answer. So here, you're seeing, again, CDB is going to be very much focused on the quality of care and looking at length of stay and that from an operational perspective. So how long did Joe stay in the hospital relative to his expected length of stay? So again, getting back to that very robust risk adjustment that we have that's done at the patient level. Did he have any complications? Why was he readmitted a week after he was discharged home? What imaging services did he receive while he was here? And did he receive antibiotics prior to surgery? So that's just a quick snapshot of some of the questions that you can answer with the clinical database. Now, on the next slide, this shows some of the types of questions that you can answer within service line analytics. So again, you'll see a different shift in the types of questions that we're answering here. So how much savings, can I possibly get out of that service line of orthopedics? And is that savings from supply utilization during Joe's encounter, pharmaceuticals? Was it from the length of stay? What's the risk-adjusted supply cost variability for Joe's surgeon? So we do look at supply cost within SLA on a risk-adjusted basis. How does the service line, why does the service line have high revenue but low contribution margin? So if there's high revenue, low contribution margin, that's going to tell you that you have opportunity related to the cost of that particular encounter, of course. And then how did the Joe's supply use affect the overall contribution margin of that case? Now you can go ahead and go to the next slide. And so again, you recall I said procedural analytics is like taking a magnifying glass in that procedural setting. The procedural setting in Joe's example is on the operating room area. And you can see here, that's why we've got that green circle around the underwent surgery area there. And so now procedural analytics is going to help you answer questions around, what was Joe's supply cost for that OR case, and how does that compare to the benchmark? Did Joe receive antibiotic bone cement? And if so, did he get a corresponding infection? What manufacturer was used for the orthopedic screws? What were the specific catalog numbers? How long was his operating room case relative to the benchmark? And then did Joe receive more units of bone cement than similar cases, so similar to the benchmark, similar to other cases even at that institution? So you can see the questions get more fine-tuned as we get deeper into the various solutions. And now we wanted to share a couple quick case studies that talk about, to Steve's earlier presentation, about how members have really taken this data and taken it from the data that's generated within the analytic tools that I just mentioned and brought them all the way to, what were the outcomes of that? What insights were they able to draw, and how did they actually implement that in their organization? Now, I'm not going to go through all of this detail here, but you can see this first example is with a Mid-Atlantic academic medical center that we work with. In particular, they were looking at their spend within orthobiologics, and we were able to help them save over $1.6 million annually. You'll see a key thing in both of the case studies that we're going to quickly review today is that all of them involved engaging the physicians and the clinicians up front in the process, and that they were a part of the analyses and a part of the insight generation throughout the entire encounter or consulting arrangement that we had here. And so here, you're looking at, they wanted to see their use of orthobiologic projects, and so in this example, we discovered variations with sourcing the products, but then we were able to look at, what was the corresponding cost of the orthobiologics, what physicians were using it, what procedures were they using it on, and then what were the corresponding outcomes for those cases, and what's the evidence saying around the utilization. And in this example, we were able to save the system over $1.6 million annually, looking at things like vendor consolidation, but of course took the approach of looking at that in a more holistic way to look at, what were those physician level comparisons, including both cost and outcomes. And that's something that I would really emphasize here. As we've talked with members and worked with members, we find that people generally tend to think of cost in one area and they think of outcomes in another. But it's really important to really marry the two together and not just look at where you can save money, but looking at those corresponding outcomes of those cases. And that's why even at Vizient, we're bringing together those two different offerings that I talked about with the clinical database and service line analytics to really drive that at our organization as well. On the next slide is just one more example. This one is specific to looking at blood utilization. And so I think all of us can relate to this one. Wanted to take a deep dive in looking at the patients that received a blood transfusion. And of course, those patients typically have an increased risk for developing, infections or other side effects. So really wanted to take a deep dive at looking at what physicians were, associated with those blood transfusions, making sure they had an awareness of the best practices. And so, like the last example, engaging senior leadership and physicians up front about looking at blood utilization, and not just for this particular initiative, but also in moving forward and having a way to kind of monitor that even after the conclusion of the initiative, of course, is a key component of performance improvement. And so here, some new practices were put in place after educating physicians on best practices, the risk involved with blood transfusion, looked at blood utilization practices across different patient types, different procedures, to look at opportunities to reduce variation there. And so in this one, there was $732K that was saved in the first year alone, and then of course they had additional savings, not to mention of course the benefits for the patients and the benefits for the clinicians of understanding the risk to those patients, which of course is first and foremost. So with that, I just wanted to give you just a taste of the different clinical analytics offerings that can help across your journey. And with that, because procedural analytics is our newest offering and many of you are not familiar with it, we did want to spend some time doing a bit of a deeper dive into that area in particular. So with that, I want to hand it over to my colleague, Bill Cotchen.
Thank you so much, Amanda. I really appreciate it. So yes, as Amanda just mentioned, it is our latest offering, but by no means new to our organization, as it was formerly a legacy product from the MedAssets company before we merged together a couple of years ago. But we are really excited to bring it to your attention today and to share with you the additional enhancements that we have made as we have been working in partnership with some of our members to continually iterate and draw out new insights and new analyses within this database. So if we can move to the next slide, I think something that you've heard from my colleagues today, Steve and Amanda both, is that no analysis is complete without connecting different data sets to tell the complete picture. As we are starting to work with different groups, not only us at Vizient, but also within the organizations that we partner with, we see that different departments are starting to come together, asking questions and looking for insights that they can't find within their own data sources. And so we need to have that common reporting platform which we can draw these from and draw insight into where we can look to improve. One of the ways that we're doing that is by mirroring the data from the clinical database with information from the source systems across the hospital. So think about your EP, cath lab, OR, IR systems. Starting to understand what can we glean from bringing these data sets together that we cannot from the legacy systems that they live in today. One of the biggest things that we often hear from members is using charge data is great because it gives us insight into some of the different revenue areas of the organization. But when we access that information, it's difficult to get down to specifically what certain supplies were that were used, who the manufacturers were, and then when we think about from a contracting perspective, how that relates back to some of the market share commitments that we have made and agreements that we have in place. So we've looked to move away from that within this database, and now it is charge code agnostic, allowing us to actually pull in some of those additional data points. Additionally, while our other systems are great in the areas that they focus on, so if we think the clinical database and being allowed or being able to leverage different types of costing methodologies in order to give the most helpful insights for our members, one of the areas that we unfortunately aren't able to show true pricing is in that database, given that it is a fully transparent database. However, we understand that in terms of identifying savings opportunities, targets, and then understanding how that will impact your bottom line at the end of the day, you need to leverage true costs when you're looking at areas like med-surg, supplies, and implants. So especially, too, when you're comparing against other facilities, we want to be able to bring that in here, and we'll show you in a second how we're able to do that. Additionally, when we're looking at utilization opportunities too, we need to have a great comparison set to understand from a categorization perspective, are you leveraging maybe too much, too little, or an appropriate amount of a certain type of supply resource? And if you're not using one supply altogether, is there an alternative that you could potentially be using? Additionally, too, we have often heard from our members, I think the most common feedback that we get is in order to make this information meaningful to us and to have us be able to share it with our physicians at the time of their, or I would say at a more timely basis, we need to get this information more frequently. So sometimes a monthly extraction is great because it allows us to leverage other different data points that we would not get until the coding occurs. But when we are looking to look at just purely cost information, we can access that information more frequently. And so through this platform, we're able to actually get an automated data feed every time a case is posted in your systems to allow us to pull out cost information on a more timely basis, whether it's daily, weekly, or even monthly. And at the end of the day, what makes all this valuable to our members is being able to establish how one resource could potentially impact your clinical outcomes and where we're seeing variation in clinical care through different supplies that are being used. So by matching this up with the clinical database or the service line analytics platform for some of our members within that space, we are able to put that full quality of care analysis together. So if we can move on to the next slide, I'd like to spend a couple minutes going through kind of how this visually has come together for organizations, what kind of data points you'll be able to glean from it, and then talk about how our members are using it today. In this first example here, what we've been able to do for our members is provide, in the clinically integrated view, the overall service line performance. So in descending order, showing not all the service lines, but in this first view, just the top 10, where your spend is compared to the peers. And your peer cohort is defined by factors you determine to be relevant for your organization. So as I mentioned earlier, it's not a transparent database because we are showing true acquisition costs in here. But you can determine certain things like bed size, region, CMI, and other factors that you want to influence your cohort. And therefore, as you update those or change those different criteria, you should see that reflected here, and potentially your variance of the cohort changed. In this example, we see that there is opportunity, and opportunity is based off of utilization of supplies within the orthopedic service line. What we can see is there's almost a $750,000 opportunity from a cost per case compared to the benchmark, and there's about a $900 variance. We see not only the cost opportunity, but we also see a clinical opportunity, looking at length of stay, complications, and readmissions. Introducing these different data points allow others in the organization, not those that necessarily reside within the quality space, but maybe within value analysis, for example, or within surgical services, being able to glean some sort of clinical information to understand, is there truly an opportunity here? Are we truly seeing variation in outcomes? Are we actually seeing some of the promises that our manufacturers have shared with us by introducing these new products actually come about in the clinical outcomes? So by no means are we providing an in-depth analysis from a clinical perspective. That would be the clinical database. But we're giving our leaders enough to be dangerous in a conversation and to have a full understanding of the clinical care and the cost ramifications for the organization. As we go into the next slide and drill down, what you're going to see is we can further expand this out, looking not only within the procedural space, but also physicians, supply categories, and facilities. In this first example here, within the procedural view, we're able to introduce the MSDRG as well as the ICD-10 and break it out even further and understand specifically by the different ICDs what is actually occurring. And so it's the same data points, but now this analysis is further refined. And from my consulting background, I can say more meaningful because it's not at the broader service line level. We know this is an apples-to-apples comparison, and we're able to actually say this is a true opportunity. As we go into the next slide here, what this is going to demonstrate is now the physician view. So you might have multiple facilities within your health system, and so at times you might want to review how your physicians are performing if they practice at more than one campus at each institution. You might want to see them aggregated as one entity compared to your cohort. But then at the end of the day, what you're trying to understand is where is the differences in the utilization. And what we have done here, and you can see for the first time, is within the supply category view, a difference, whether it's knee implants, joint products, bone cement, or other surgical products related to the case. What we are leveraging internally is our own categorization schema, partnering with our clinical consultant needs within the different service line areas to put this together for our members so that we can introduce this and pinpoint exactly for you where the opportunities are, so that you yourself are not sitting there combing through the data and looking for variation and having to do it through extensive Excel spreadsheets, as we often see as the case today. At the bottom of the screen, too, you will see the individual physicians as well as their numbers at a high level. We will see how they compare to that cohort and, again, to the clinical differentiators. Now, the one thing that's really important here is sometimes we will see a positive result as a result of increase in cost. And that's okay, and that's what we want to actually see if that is truly the case. But we might not necessarily be able to glean that information if it wasn't put together in a comprehensive reporting platform. And you can start to understand and see that if we only had the cost component of this conversation, we might move forward with something that we wouldn't necessarily want to because we want to understand that it is actually benefiting the health system from a clinical perspective. So by including all these insights together in one view, you're in a better stance when you go and speak with a physician. And the next view as well, too, when we get into the supply categories themselves, we can further refine this information. And while we don't have all the screenshots here of the different drill downs, when you get into these, we start to further expand them out so that we're telling you within the knee implants specifically, there is an opportunity within tibial inserts, for example. And then further within that tibial insert, where is it exactly? What type of component? So is it within the rotating platform? Is it in the fixed bearing component? Again, additional insights that we provide you that your own analysts do not have to spend the time combing through. And we're doing this based off the catalog IDs that are coming across to us. So really taking what most of you may be familiar with in terms of an unspec categorization a bit further. Also down below, for the first time, we are integrating GPO level information into this through the Vizient Savings Actualizer with benchmarking platform. And so within the knee implant supply category line, you will see the price index of 27.5. So for those of you who are not familiar with the price index, the closer to zero, the better in terms of overall contracting. But if that index was higher, maybe it was above 50, this could also potentially be a pricing opportunity. And you would want to go back and partner with those in contracting to understand, are there certain agreements in place that prohibit us from maybe going forth and asking for additional discounts? Are there consolidation efforts that we can do to standardize and maybe see and increase market share and therefore lower pricing? And again, too, how will this ultimately, at the end of the day, impact utilization if we do or do not have certain products available, and additionally, the clinical outcomes. And then in the final screen here, we do also have a facility view available for our members. So this will allow you with those multiple facility health systems be able to see how the individual hospitals are performing on their own, and then in an aggregated form. At the end of the day, all the drill downs will get you to the same level of information. So we'll go all the way down to the patient records, should you be looking for that. We'll provide everything from timestamps associated with the different procedural cases, as well as the staffing information on those cases, so that you can always reference back with the actual clinicians that service this patient. But then also, too, if there are any issues, so complications or readmissions or length of stay questions, you would be able to actually go back and understand from the patient record exactly what is pulling in. So by incorporating all these different insights together, we're able to move the conversation forward in an area that we have not been able to in the past, and that we really feel at Vizient we are a leader in, given some of the different data sets that we already have available from our members and our very diverse portfolio of analytics, and by incorporating those together into new insights. So as we've launched this and as we speak with our members, we're getting really great feedback. We launched this formally at the Supplier Summit, or Vizient Connection Summit, that happened earlier this month in Las Vegas, so some of you may have been familiar with it there. If you were not able to join us, good news is that your colleagues and your peers in the marketplace are happy. They're seeing good opportunities come for this and areas to improve that they were not familiar with before. And always what we like to hear, if they have a tool, they would love to be in it every day. So we are thinking about new ways that we can continue to expand the analyses. So is it thinking about reimbursement information? Is it thinking about incorporating operational efficiency metrics? We are always looking for ideas and incorporating feedback from our members as we continue to iterate on this. And so when we think at the end of the day, after everything that both Steve, Amanda, and myself have shared with you this afternoon, when we think about what makes Vizient different, I believe first and foremost that it's really our ability to connect the clinical, operational, and supply insights into a common reporting platform, and our unique ability to help members tie decisions around cost and utilization with their quality and outcomes implications. I also think from a transparency perspective, our comparative analytics have created an organic and unique improvement community amongst our members. We are very focused as a company on helping our members learn, improve, and build together. And through our risk models that have been tested time and time again, and I would say even further clinician tested, we've ensured that the conclusions we're drawing off of our analytics can be substantiated with the physicians who are looking at this information. And then I say finally, too, a broad set of capabilities all the way from strategy through execution, which we think will be critical for our members as they transition to value-based care and population health. So if you look at Vizient, and we believe we are unique in this ability to help our members understand and shape the trajectory of their markets, design strategies, and address those trends. We can help them both implement those strategies and enable the performance and management through the analytics platforms that we have, and ensure that what you're seeing when you're talking with your physicians and sharing this information are changes, and that those changes are substantial, they're sustainable, and that we're being able to kind of monitor the implications of those through analytics over time. So I'm going to pause there. I think we left about 10 minutes here for questions and answers. So I do believe we have a few extra questions we'd like to share with you. So Greg, I'll turn it back over to you if you would like to speak with the audience.
Thank you, Jill, so much. And I appreciate you, Steve, and Amanda walking everybody through the performance improvement equation, Steve, and then also the platform overview and the overview for procedural analytics. Very, very helpful. We do have a couple of final polling questions that we'd love to receive your feedback on. I'll go ahead and click through those. Polling question number 2 is now on the screen. It will help us know how relevant and how helpful today's content was for you to respond. On a scale of 1 to 5, with 1 being very helpful and 5 being completely unhelpful, how would you rate the content today? 1, very helpful, 2, helpful, 3, neutral, 4, unhelpful, and 5, completely unhelpful. And while you're responding to that question, I do want to remind you that I'd love for you to type into the Q&A any questions that you may have regarding the content that you've seen today. We may have some time for a few of those questions, so feel free to type in those questions and send them our way. And Connie, if you could let me know when we've reached critical mass on this question, we can move to the final polling question and then have time for questions.
Please go ahead.
Okay, great. Our final polling question is the following. Recognizing that each of these technologies can work together but also operate independently, and taking into consideration what you heard today about the specific technologies, we'd love to know which of these solutions that you'd like to learn more about. 1, clinical database, 2, service line analytics, 3, procedural analytics, 4, all of the above, or 5, none of the above. Again, I would like to receive more information regarding CDB, SLA, procedural analytics, all of the above, or none of the above. And as you're responding to that question, I will take a look at the Q&A that's come in. So one question that's come in is procedural analytics available now? And I believe the answer is yes, it is available now. It was launched, as Jill mentioned, at the Clinical Connection Summit earlier this month, and it is available to our members.
Yes, that is correct, Greg.
Another question that came in that's an interesting one related to what Steve presented is, who is typically the ideal kind of data champion or data scientist in an organization? Is it the clinician? Is it a nurse? Is it a physician? I don't know, Steve, if you're still on the phone, if you could respond to what you've seen really work in organizations related to who that data scientist is and how they relate to the rest of the organization.
Yeah, what an absolute wonderful question, because that's something that there's quite a bit of debate over. Some folks would believe it would be a clinician of some sort, a physician or a nurse, because of that healthcare proficiency. But the best data scientists that I've seen are not clinicians, and that's because they don't necessarily understand the in-depth nature of what this drug does or that drug does, but they do understand variation, meaning that why would one be different than the other, and then they can go and simply be curious and ask those questions. So I would say that, you know, it obviously depends, but it's those 5 characteristics that you need to find in an individual. I don't think, though, that it absolutely necessarily has to be a clinician. In some cases, I think that hurts.
Thank you, Steve. Another question that we're getting is, sounds like there's a couple of folks on the phone that have OR Explorer, and I understand that procedural analytics will replace OR Explorer. When can my organization expect to transition to the new solution? I don't know if Amanda's on the phone.
I can take this one. This is Amanda.
Okay.
Yep, I can take this one. So what we're doing, so we recognize our members that are on OR Explorer will have to transition to a new product with procedural analytics. So we are going to keep OR Explorer up and running through the remainder of 2018, and then we are working through conversions with each member on a one-on-one basis. So we'll be reaching out to those members that are OR Explorer to help coordinate a time that makes sense for both Vizient and for you as the member to transition over to procedural analytics. So don't worry if you're one of those organizations. Like I said, we have no intention of shutting down OR Explorer anytime soon until we've gone through all of those conversions and folks are comfortable.
And how long does it take to get SLA and procedural analytics up and running within an organization? Amanda, were you able to hear hear that question in terms of implementation.
Sorry, yeah, I couldn't unmute. So for procedural analytics, rather, it's a much lighter lift. The file spec, it's really only 4 files, 3 of which are more of the mandatory files. So it's a fairly straightforward data pull. We've had to work with some of our members on various data quality issues. And so that can obviously vary just depending on how many resources that you have at your organization, how quickly you can respond to the requests. We've had some members implement in as little as a month, and other times it takes 3 months. SLA, CDB, those products, because they are a little bit heavier of a lift in terms of the data specification, we generally say a range of anywhere from 3 to 6 months.
Okay, great. And how would a member get access or gain access into these solutions once they're implemented?
So once they're implemented on this solution and we've got their data in-house, it's gone through all the data quality checks, and it gets uploaded into the tool. Generally speaking, with the CDB and with procedural analytics, for example, there's someone designated at your institution to grant access. We generally refer to those as either a CDB coordinator or a procedural analytics coordinator, and then that person will be able to turn on access for individuals at your organization because they're really in the best place to know whether someone should be able to access that protected health information or not.
Thank you. Here's an interesting question that's come in. Does the data captured include and cover any outpatient or physician offices that are part of a healthcare system beyond the hospital?
Yeah, so for really all of our clinical analytics offerings, the hospital-based outpatient data will be included. So you'll see that in procedural analytics, you'll see that in the CDB, but for physician office visits, those are captured in a separate analytics tool that we have. It's the Faculty Practice Solution Center. That's really focused around more of that physician-centric viewpoint, from a physician office-centric viewpoint, I should say.
Thank you. I'm a Vizient Savings Actualizer user. How exactly is Savings Actualizer different, and how does this technology complement Savings Actualizer?
Sure, I can take this one as well, and Jill, feel free to jump in too. So Savings Actualizer is going to look at all of your purchase order data to see what supplies you've purchased and how competitive your pricing is relative to others that are purchasing that same item. But when you're using Savings Actualizer, and of course that would be more of a supply chain specific persona that would be using that application, if you want to know then what happened to that product once you purchased it, meaning what procedures was it used on, what physicians used it, what patients received that item, you can't get to that level of detail within Savings Actualizer. And so that's really where procedural analytics and service line analytics come to play, is it starts connecting all of the supplies that have been purchased to the actual patients in those encounters. And so that's the key difference there.
Yeah, just to add to what Amanda said, this is Jill here, is one, the personas are different, as she just explained. So commonly we will want somebody who, maybe is more in a clinical setting to really leverage some of the insights that we're seeing come out of the procedural analytics tool, given that it has that outcomes information, but also partnering with those within supply chain contracting value analysis to decide ultimately from an organizational perspective how you guys want to prioritize some of your contracts with your vendors and what products you might want to standardize with. So I think everything that Amanda just said, but the tools are intended to just look at different levels of detail. I would say more pricing opportunities versus clinical utilization opportunities.
What EMR data sources do you work with?
Sorry, Greg, can you repeat that one?
Yeah, I can.
Go ahead, Steve.
The question was, what EMR sources do we work with? For the clinical data, well, actually for all of our products, we're really EMR agnostic. Those that are in the clinical database, for example, that are sending us the 14 files that we need, many of those are actually getting those out of a data warehouse, so they're not going directly to the source systems. I know that in procedural analytics, we've done some great work with Epic and we're starting to do better work, I guess, with Cerner. But for the most part, would Amanda, Jill, you guys agree that we're kind of EMR agnostic?
Yep, absolutely.
Mm-hmm. I think Jill might have touched on this question, but how current is the data that flows through the systems?
Yeah, so the clinical database as well as service line analytics will take in a monthly fee. So usually for those systems, it's around 45 days post-close in a month. So we do have some members that are early submitters that meet criteria from a data quality and completeness perspective. But if you use March, for example, we would typically be receiving that information by May 15th of this month. With the procedural analytics, we have two views that we mentioned, the supply-only view as well as the clinically clinically integrated view. Excuse me, a little tongue-tied there. The supply data-only view can come in as frequently as daily, weekly, or monthly. We really leave it up to the member as to how frequent they would like to set up that automated feed. When you're looking at the clinically integrated view within procedural analytics, it will refresh as the clinical database or service line analytics information refreshes on a monthly time frame.
Thank you, Jill. I think our hour is up. One last question that I'll address before we say goodbye is there was a question about where will this solution show up? Will it show up under My Tools within the member dashboard? And that answer is yes. Where all of your other solutions are, when you get access to that, you'll be able to have access that way. Want to just sincerely thank you for taking time out of your day to learn more about clinical analytics in the program. Thank you to our presenters. Y'all have a great afternoon, and we'll talk again soon. Bye-bye.